Welcome to Academy of Ultrasound's online echocardiography course. My name is John Sheldon. I'm one of the instructors here at the Academy, and I'll be holding the lesson for this particular session. This session we're going to be dealing with Echo232. We're dealing with week 4, which happens to be chapter 13 in your Feigenbaum book, specifically pages 388 to 396. We've already spoken at great length about endocarditis. So tonight we're going to continue that discussion, and let's talk mainly about prognosis and predicting risks. The books and the materials that you'll find say that the only echocardiography-based parameter consistently associated with increased risk is vegetation size. Depending on the size of the vegetation is what determines the risk. The larger the vegetation, the greater the likelihood of complications, particularly embolic events. You need to know figure 13.24 on page 389, so let's scroll down and take a quick look at it. It's an example of a large vegetation involving the aortic valve. This is the aortic valve with this large vegetation in the middle. You need to be aware of this picture because you may see it again on your registry. That little piece in the middle of where your normal aortic valve would be is a large vegetation. So next, let's move on and talk about prosthetic valve endocarditis. As you already know or should know, prosthetic valves are highly reflective to sound waves and cast a pretty impressive shadow. The effect of the device being implanted on the underlying tissue make diagnosis difficult. This shadow keeps us from really seeing with great clarity compared to seeing with a person that does not have a prosthetic valve. However, vegetations on prosthetic valves occur most often on the base or the sewing ring of the structure, and we can see that in figure 13-25. This particular patient has a St. Jude mitral prosthesis. They have a large vegetation that's showing, again, this time on the top in the LA section or in the left atrial section. You get this drop down, this shadowing drop down that prevents us from seeing much on this side, but in this case, the vegetation is on the upstream side of the valve. Transthoracic echocardiography is limited in its ability to secure the diagnosis of prosthetic valve endocarditis. Transesophageal imaging is most helpful, so let's go take a look at a picture from a transesophageal or a TEE, which is figure 13.27. This particular image that you're looking at now actually came from a TEE. And you can see that it is a stentless aortic valve. It's thickened and echogenic. A short axis view demonstrates abscess formation. This area here is a formation of an abscess around the sewing ring. Color Doppler imaging reveals flow within the abscess cavity. This area right here, see the flow? There should not be any flow outside the actual valve orifice itself. So what does this mean to you as an echocardiographer? It means that it's common and very, very normal to have to do both a transthoracic and a TEE study on the same patient to try to determine with a prosthetic valve if there's a vegetation, if they feel that the symptoms and the indications are leaning towards vegetation, and we cannot see it on transthoracic, then obviously we want to go to a TEE. All right, so moving on. Infected endocardiac devices. Anytime you have a prosthetic material inside the heart or vasculature, it can become infected. Infection can occur early or later after implantation. They are difficult to treat without removal and are associated with a poor prognosis. An infected pacemaker lead is shown in figure 13-30. Multiple pacemaker leads in the right heart. These mobile masses where the arrows are consistent with vegetations on the pacemaker leads. In most cases, infection is going to require a TEE, or transesophageal. Distinguishing vegetations from thrombus is virtually impossible on echocardiography grounds alone, and it requires clinical correlation. Thrombus does not give the same clinical symptoms that a vegetation does, such as endocarditis, dealing with fever, a fever of unknown origin specifically. So if you want let's talk about right-sided endocarditis. Endocarditis involving your tricuspid valve is most commonly seen in a setting of intravenous drug use. So you need to know the patient's history. If there's a history of drug use, it's perfectly possible that you can have a right-sided endocarditis. Figure 13-31 that you'll see on the left side of the screen shows a tricuspid valve vegetation. You get blowing TR, large TR gradients, and you obviously see the vegetations that are on the tricuspid valve that are floating around in the RV and RA area as the valve opens and closes. Vegetation sizes on the right side tend to be much larger and greater. Tricuspid regurgitation is generally present. Pulmonary valve vegetations are less common and very difficult to visualize because we don't really get a terribly good look at the pulmonary valve in most adult studies. Complication of pulmonary artery catheterization could be a vegetation. A small vegetation example is seen in 13-32. Let's take a look at it. This is involving the pulmonary valve, very, very small vegetation that you see on the pulmonary valve. Right here and here where the dot is. So how do we deal with a patient that has endocarditis? Guidelines for the use of echocardiography in patients with known or suspected endocarditis are presented in Table 13-8. You need to be aware of Table 13-8. You don't need to memorize it, but just be aware of it. Indications for echocardiography in infective endocarditis with native valves is the detection and characterization of valvular lesions, detection of vegetations, I don't want to go through the whole thing. You can read this on your own, but be comfortable with the 10 reasons. Down here would be evaluation of transient fever without evidence of bacteremia or a new murmur. Non-staphylococcus bacteremia, number 7, without a known source. There are lots of different things that cause you to think about endocarditis and why we would use echo. The results help establish or exclude, this is echo now, the diagnosis and provide prognostic information, establish a baseline for comparison, identify patients in whom prompt surgical intervention is recommended. Transthoracic echo is the initial test of choice. TEE is considered an initial test of choice with patients whose image quality on chest wall imaging is unacceptable. This would be your large body habitus individuals, those with prosthetic valves, and those in whom complications such as abscess formation are suspected on clinical grounds. So if you know it's going to be a tough case, you probably want to discuss with your physician about going straight to TEE. However, it is very common that you can find these vegetations, if you know what you're looking for and where to look, on the valves, specifically on the valves, or any external devices, pacemaker leads, those kind of things that would be in the heart. Anything abnormal, anything prosthetic. So as always, please take these lessons and go to Google, do some searching on your own about infective endocarditis, prosthetic valves. If you find anything that you're not comfortable with, please send a copy of it or a link to it to John at academyofultrasound.com, and I'll do my best to look at it and try to help you interpret it. There's much stuff out there that you can find with pictures. The more images and pictures you see, the more ready, better ready, able you'll be to take your registry when it comes down to it and to be an echocardiographer in the field. Please also check the DVD that came with your book. It has a lot of impressive images with it dealing with each chapter. So for tonight, that's John Sheldon with the Academy of Ultrasound, and keep studying. I look forward to talking to you at the next session.